For many, many years we had just single-agent endocrine therapy. We have now data from combination studies with endocrine therapy and CDK4/6 inhibitors. I think the results are substantial and are changing the way we look at endocrine therapy in the first-line metastatic setting. First of all, we have now consistently demonstrated across 3 randomized phase 3 trials that single-agent endocrine therapy is actually very effective in this. And the Paloma 2 trial, the Mona Lisa 2 trial, as well as the Falcon trial, all showed activity for aromatase inhibitors of median progression-free survival of between 30.5 and 14.5 months. The second thing we can say is the results of the trials we saw here show that a different endocrine therapy given alone can also increase progression-free survival, especially for a subgroup of patients who have non-visceral disease, where with fulvestrant, a median progression-free survival of about 22 months was observed in this trial, which again is very substantial. And then we know that the patients who get upfront a combination of endocrine therapy and a CDK4/6 inhibitor have on average a progression-free survival of more than 2 years. And what I would say is there remains a role, and a significant role, for single-agent endocrine therapy, for example with patients with low disease activity, slowly progressing disease, who possibly had a relatively long disease-free interval, where we think they have really endocrine-sensitive disease. Those are good candidates for a single-agent endocrine therapy at a time when we haven't got data on overall survival of the combination studies and haven't got real detailed data on how patients do on subsequent therapies. I think the biggest next steps in the field of endocrine therapy is really to look at the long-term outcome of these patients. We need to see, is there survival benefit associated with early use of CDK4/6 inhibitors. We also need to see what happens to patients once they progress on CDK4/6 inhibitors. We always say patients with ER-positive breast cancer should receive initially endocrine therapy unless there's impending visceral crisis. Reality is quite different depending on which country you're in. In some countries, 60 to 70% of patients receive upfront chemotherapy even if they're ER positive. What we've now seen in both Paloma 2 and Mona Lisa 2 is objective response rate of over 40%. 40% is a high response rate that's not easy to achieve with chemotherapy as well. So what I would expect and what I would hope to see, so we also have a shift towards using less chemotherapy upfront and using more endocrine therapy, and here in the combination of endocrine therapy and CDK4/6 inhibitors.